thanks again, Libby, for doing this.
Yes, we appreciate you.
Thank you. Can everyone see the presentation?
Yes, we can see it.
Perfect. Well, thank you again for that introduction and for this opportunity. I have no relationships to disclose in regards to the content referenced in today's presentation. In today's presentation, we're going to look at defining atrial fibrillation, discussing risk stratification strategies for stroke prevention, explore our oral anticoagulation options for stroke prevention in patients with atrial fibrillation, have the ability to select an oral anticoagulant based off of our landmark trials, special populations, as well as unique clinical scenarios, and then looking at the reverse side of it, looking at reversal strategies for these oral anticoagulants and using patient-specific criteria to make that selection. Atrial fibrillation is the most common arrhythmia seen in clinical practice. It's caused by or characterized by uncoordinated atrial activation with decreased mechanical functioning and also decreased atrial emptying. This allows blood to pool in the left atria and the left atrial appendage, which allows for clot formation. An embolus can break off of that clot, leading to an ischemic stroke. So when we talk about being the most common arrhythmia, this is one of my favorite slides called AFib by numbers, or atrial fibrillation by numbers. AFib occurs in currently 2.2 million Americans in the United States, and that's projected to increase to 12.1 million by the year 2050. And this is a big deal because stroke-related care due to atrial fibrillation has a significant morbidity and mortality. There's almost 750,000 hospitalizations each year, with 130,000 associated deaths. And this increases as our population gets older. Patients over the age of 80 are 23% more likely to develop atrial fibrillation, and it's the cause of almost 25% of all strokes in the elderly. These people are 2 times more likely to be bedridden from a stroke, and right now our Medicare costs are roughly $8 billion and is projected to increase. So in addition to age, there are risk factors that we can look for to identify patients who are likely to either get atrial fibrillation or to have an atrial fibrillation-related stroke. In addition to age, that would be congestive heart failure, hypertension, diabetes, and a prior stroke or TIA. Overall, stroke prevention is complex with the ultimate goal of being at maximum treatment effect with low complication risk. And for us, that means usually bleeding. Helping to achieve the goal, we can use risk stratification tools, such as the CHADS2-VASc, to identify our high-risk stroke patients, and then also use the HAS-Blood scoring system to identify patients who are high risk of bleeding. We can use these systems to do secondary stroke prevention treatment with anticoagulation. The CHADS2 system was developed in 2001, followed shortly by the CHADS2-VASc risk stratification system in 2009. And they're used to identify our high-risk stroke patients who have atrial fibrillation. Despite the addition of ages 65 to 74, vascular disease, and female sex in the CHADS2-VASc system, both systems agree that patients with a score equal to or greater to 2 should get oral anticoagulation, and patients who have a score of 1 should at least be considered. But selecting an oral anticoagulant is not as easy as selecting a cookie out of the cookie jar. Providers must consider acuity of therapy, special population, bleeding risk, patient compliance, affordability of the medication, as well as drug interaction. So with all the choices, considerations, and the goal of maximal effect with low bleeding risk, how do we always know the right agent to choose for our patients? So let's meet them and decide. The first oral anticoagulant utilized for AFib-related stroke prevention came on the market in 1954, and that's going to be our vitamin K antagonist, Warfarin, also known as Coumadin, or less commonly, Jantoven. Decades later, we've had our first direct-acting oral anticoagulant, or DOAC, called Dabigatran, or Pradaxa, that came to the market in 2010 for AFib-related stroke prevention. Shortly thereafter, there was our first factor Xa inhibitor, Rivaroxaban, or Xarelto, and then Apixaban, or Eliquis, and then Andoxaban, or Savaysa. Well, let's discuss these agents in greater detail, beginning with Warfarin. Warfarin is one of the oldest anticoagulants, and it inhibits vitamin K epoxide reductase, which is a great way of saying it inhibits clotting factors 2, 7, 9, and 10. And as you can see here, here's our Warfarin acting here, here, and here on our 4 factors. But it also inhibits our natural anticoagulants, protein C and protein S. It is the drug of choice for valvular atrial fibrillation, but it can also help treat venous thromboembolism, or VTE, certain hypercoagulable disorders, atrial and ventricular clots, and other cardioembolic strokes. So looking at valvular atrial fibrillation, a lot of people will ask, well, what does it mean to have valvular atrial fib? This can include severe mitral stenosis, rheumatic heart disease, or prosthetic heart valve. Warfarin is the drug of choice in these patients since most of the DOACs excluded valvular AFib patients in their landmark studies, but even their definition of who they'd exclude was inconsistent. When looking at Warfarin, the usual dose is 5 milligrams nightly, but providers should be considerate of disease state interactions that could necessitate a lower dose or maybe an increased dose. For example, conditions known to increase the INR would be hyperthyroidism, fat malabsorption, patients who are of advanced age and may be malnourished, but there are people who naturally have a high vitamin K diet, who are hypothyroid, who have tobacco use or chronic alcohol use. They are known to decrease the INR and may need a slightly higher dose. Dose adjustments should be made every 2 to 3 days, given the long half-life of a few of the factors that Warfarin inhibits, to get to our goal INR range of 2 to 3 in most patients. The goal of 2.5 to 3.5 may be optimal in certain patients with valvular heart disease and antiphospholipid antibody syndrome. In addition to the disease states that interact with Warfarin, providers should consider drug interactions and food interactions. Now, there are many drugs that will interact with Warfarin given its hepatic metabolism. However, the one thing I would like for you to remember as a pharmacist, the FAB5. So FAB5 or FAAB5. That's fluoroquinolones, azole antifungals, amiodarone, Bactrim, and Flagyl makes 5. Those are the big ones to take a look out for. In addition, with our neurology patients, phenobarbital, carbamazepine, and phenytoin do have significant interactions as well. Then we know that with Warfarin, there is a dietary interaction in that a diet that's high in vitamin K intake will decrease, or as I tell my patients, make Warfarin work harder. It's not about omitting these foods, but it's about being consistent so our INR can be consistent. Most patients find it's easy to just omit this so they don't have to have a food diary or think about every single meal. We generally say it's the green leafy vegetables, but don't forget about mayonnaise, canola oil, kiwis, blueberries, and cauliflower. A lot of patients do forget about these, and then we wonder why their INR is so variable. Patients with an acute clot or at high risk for a clot should be bridged with parenteral therapy. That's usually referring to unfractionated IV heparin or low molecular weight heparin for a minimum of 5 days and until the INR is at goal. This is mostly going to be for our patients who have a left atrial clot or left atrial appendage clot or even an LV thrombus. This is because when you start warfarin, you are prothrombotic due to the inhibition of our natural anticoagulant. And like I said, some of the factors take a long time to be inhibited. Factor 2 has a half-life of 60 to 72 hours, so it could take up to that 5 days for factor 2 to be fully inhibited. Not all AFib patients are going to need parenteral bridging. Some providers will consider aspirin plus warfarin until the INR is at goal and then remove the aspirin. However, there's limited evidence in this. This is all about meeting that goal of maximal treatment effect with low complications, and we're lowering our complications by decreasing the risk of bleeding. Know that in our pregnant patients, warfarin is contraindicated, and additionally, since it has been on the market for a long time, warfarin is very inexpensive. It's about $4. It can be on some $4 lists, but INR costs can be INR checks can be costly, and this is controversial in non-compliant patients. Patients who are not totally compliant with warfarin, you may be able to get by with a therapeutic INR at a day or two after a missed dose. However, these patients, it's theorized that they may not be willing to go in for weekly INR checks and monthly INR checks. So non-compliant patients can be controversial to get warfarin. With all of the drug, disease, and food interactions with warfarin, you can imagine it's hard to remain in the therapeutic range. So what do we deem acceptable? So we deem that time in therapeutic range for warfarin is up to 70%. We know that at 70%, there's a 2/3 in stroke reduction in AFib patients, and it can reduce mortality by 25% compared to aspirin or placebo. This means that patients usually need to get a weekly INR check to start until their perfect dose is found, and then monthly. However, new drugs, new diseases that the patient acquires can affect the time in therapeutic range, so then you have to consider if warfarin's the right choice for you at that point. So to sum up warfarin, its benefits are that it is approved for valvular atrial fibrillation. It is the most predictable oral anticoagulant in severe renal impairment, and it has the most data with our atrial clots. It is inexpensive, but this comes at the cost of slow onset of action, maybe needing parenteral bridging. It has a narrow therapeutic window that does require INR monitoring. It does require dose adjustments as there is no fixed dose per patient, and it does have numerous drug and food interactions. So looking for something different, we have our first direct thrombin inhibitor, Dabigatran. Dabigatran works differently from warfarin in that it only inhibits factor 2A or thrombin and decreases the conversion of fibrinogen to fibrin. It additionally is indicated for VTE treatment. And it got its indication for stroke prevention and atrial fibrillation through the randomized evaluation of long-term anticoagulation therapy trial, or the RELY trial. This evaluated Dabigatran 110 milligrams and 150 milligrams twice daily versus warfarin, with a target INR goal of 2 to 3. This was a randomized open-label trial that enrolled 18,000 patients with an average CHADS-2 score of 2.1. They followed these patients for up to 2 years, and their time in therapeutic range on warfarin was 64% in the patients who got warfarin. Ultimately, Dabigatran was found to be superior to warfarin in fewer overall strokes and systemic embolism, fewer ischemic strokes, and fewer intracranial hemorrhages. However, this did come at the cost of higher rates of gastrointestinal bleeding, and it was found that the lower dose of Dabigatran was non-inferior to warfarin with no significant reductions in ischemic stroke. Given the superiority, the FDA only approved the 150 milligram dose of Dabigatran to be used in the United States. It does have to be dose adjusted for renal dysfunction, and if you're using it to treat a patient for a VTE, it requires 5 days of parenteral therapy with unfractionated heparin or low molecular weight heparin. It has to be kept in the original container, or it could compromise its ability to anticoagulate, and it cannot be crushed by crushing this medication, you increase the bioavailability by up to 80% and increase the patient's bleeding risk. While there is no routine monitoring needed with Dabigatran, eccrine clotting time and thrombin time increase linearly with Dabigatran concentration. Now, you should note that Dabigatran also prolongs the APTT and INR, but this should not be used to measure treatment as it isn't dose dependent. Avoid use with certain P-glycoprotein inducers and inhibitors, such as amiodarone, verapamil, rifampin, or carbamazepine. Unlike warfarin, there is limited evidence in pregnancy, and this can cause dyspepsia in patients. Unlike warfarin as well, it is expensive. So patients without insurance, this is costing over $400 a month. Overall, Dabigatran has no laboratory monitoring or no routine laboratory monitoring, as minimal drug interactions, and this was found to have significant ischemic stroke reductions compared to warfarin. However, there is increased GI bleeding. It is expensive. Again, there is controversy in non-compliant patients, as if a patient misses a dose, the therapeutic concentrations decrease significantly, leaving the patient at risk for an ischemic stroke. And there is limited monitoring for when we do want to monitor. Following Dabigatran, we have our factor Xa inhibitors. Like Dabigatran, our factor Xa inhibitors work on one portion of the coagulation cascade at factor Xa, decreasing the conversion of prothrombin to thrombin. In addition to VTE and non-valvular atrial fibrillation, these medications are also used for VTE prophylaxis after hip and knee replacement. Dose and dose adjustments depend on risk factors and renal function. The trial of Rivaroxaban once daily oral direct factor Xa inhibition compared with vitamin K antagonism for the prevention of stroke and embolism trial in atrial fibrillation, I know that's a mouthful, but it's called ROCKET-AF, was the trial that helped bring Rivaroxaban to the market first. This looks at Rivaroxaban 20 milligrams once daily versus warfarin in stroke prevention in atrial fibrillation patients. Our goal INR was 2 to 3, and unlike the RELIDE trial, this is a randomized double-blinded trial, and it included less patients at about 14,000 patients. They did have more risk factors per patient with an average TADS-2 score of 3.5. They were followed for almost 2 years, and their time in therapeutic range was actually less than the RELIDE trial, at 55%. Overall, Rivaroxaban was found to be non-inferior to warfarin, with fewer overall strokes or systemic embolism, fewer hemorrhagic strokes, fewer intracranial hemorrhages, but again, higher rates of GI bleeding. Rivaroxaban showed no significant reductions in ischemic stroke compared to warfarin when that was teased out of the composite endpoint of overall stroke or systemic embolism. This was mainly driven by its lack of hemorrhagic strokes or intracranial hemorrhages. Like Dabigatran, the dose does vary based off of the renal function. For hip and knee replacements, you're going to see this odd dose of 10 milligrams daily. If you have a patient coming into the hospital on Rivaroxaban 10 milligrams daily, this doesn't mean they were at an inappropriate dose. Just check their chart or check in their history to see if they had a previous knee or hip replacement. For VTE treatment, it is not required for Rivaroxaban to be bridged with parenteral therapy, but you will see 15 milligrams twice a day used for 21 days and then 20 milligrams daily. As a pharmacist, we have our red flags up for the 21 days just because patients tend to forget to either switch, but now we have great starter packs available on the market. Have the first full month of therapy in one so they know exactly when to switch. So it takes a little bit of the guesswork out for the patient. But we shouldn't be using this in patients with a creatinine clearance less than 30. For our atrial fibrillation patients, where we'll see this most often, we just do 20 milligrams daily. So we can forget the 15 BID. However, we may want to reduce the 15 milligrams nightly in patients with a creatinine clearance less than 50 mils per minute and avoid it in patients with a clearance less than 15 mils per minute. Rivaroxaban should always be taken with food because this can increase the absorption of the drug and make the absorption adequate. In the same year as ROCKET-AF commenced, the trial of Apixaban for reduction in strokes and other thromboembolic events in atrial fibrillation, or ARISTOTLE, also was started. This evaluated Apixaban 5 milligrams twice daily versus Warfarin, again with our standard INR goal 2 to 3. It was a randomized double-blinded trial that included up to 18,000 patients, and they had a few less risk factors per patient with the average CHA2 of 2.1. They were followed up to almost 2 years, and their time and therapeutic range for the Warfarin patients was higher at 62%. Ultimately, Apixaban was found to be superior to Warfarin in fewer overall strokes or systemic embolism, fewer hemorrhagic strokes and intracranial hemorrhages, and it also had a lower rate of death from any cause. There were no significant differences when it came to its ability to reduce ischemic stroke, but it also did not show a higher rate of GI bleeding compared to our other DOACs. Like the other DOACs, the dose is going to depend on your indication and patient's renal function. Hip and knee replacements are going to be that standard 2.5 milligrams twice a day, regardless of patient's age, weight, or renal function. For VTE, you're going to see this uncommon dose of 10 milligrams twice a day for 7 days, because unlike Xarelto, Apixaban or Eliquis does not require parenteral therapy when treating a VTE. After that 7 days, then you would reduce to 5 milligrams twice a day. Note that in the studies that brought this to market, that for VTE treatment, they did not include patients with a creatinine greater than 2.5 or creatinine clearance less than 25 mL per minute. In looking forward to our AFib patients, the standard dose is 5 milligrams twice a day. However, we reduced it to 2.5 milligrams twice a day in patients who meet 2 of the 3 criteria. Most of the time when working with people who are starting or unfamiliar with Eliquis, everyone remembers at least one, but remember you have to meet 2 of the 3 criteria, and that's age greater than 80 years old, weight less than 60 kilos, or a creatinine greater than 1.5. Then you will reduce to 2.5 milligrams twice a day. Lastly, we have the effective anticoagulation with factor Xa next generation in atrial fibrillation, thrombolysis, and myocardial infarction 48 trial. This is the ENGAGE-AF TIMI 48 trial that helped bring Edoxaban to the market for AFib-related stroke prevention. This study evaluated Edoxaban 30 milligrams or 60 milligrams once a day versus Warfarin. It was a randomized double-blinded trial and is our largest DOAC trial for AFib-related stroke prevention at 21,000 patients and an average CHA2 score of 2.8. Patients were followed the longest in this study for a median of 2.8 years and had time and therapeutic range for Warfarin patients in 65%. The 60 milligrams of Edoxaban was found to be non-inferior to Warfarin in overall stroke or systemic embolism, and also has fewer hemorrhagic strokes or fewer intracranial hemorrhages. There were higher rates of GI bleeding in the Edoxaban 60 milligram group and showed no significant reduction in ischemic stroke. They actually saw the Edoxaban 30 milligram group had higher rates of ischemic strokes with favorable bleeding outcomes compared to Warfarin. Based on the ENGAGE-AF TIMI 48, the 60 milligram dose of Edoxaban is approved for VTE and AFib in the United States. The only time we would reduce to the 30 milligram dose daily would be a VTE patient who weighed less than 60 kilos, or if the patient had a creatinine clearance less than 50 mL per minute. I call this the Goldilocks drug because you should avoid use with patients with severe renal dysfunction or patients who actually have really good renal dysfunction in atrial fibrillation, because it was seen that the patients with a creatinine clearance greater than 95 mL per minute, these patients actually cleared the drug more quickly and cleared the drug more, and were not protected and were not anticoagulated. So just remember that Edoxaban or Savasa should not be given to our patients with really good renal function. If we are using it to treat a VTE, then we do need to require 5 to 10 days of parenteral bridging therapy as well. Overall, there are no conventional laboratory tests needed to monitor the anticoagulation status in people who are on factor Xa inhibitors. However, calibrated anti-factor Xa assays and a prolonged PT for Rivaroxaban only may be helpful. Now remember, if your hospital does heparin anti-Xa assays, that cannot be used to monitor Rivaroxaban or Apixaban or Idarucizumab. It has to be calibrated to the specific drug. Again, controversial in non-compliant patients with the black box warning of increased ischemic events after acute discontinuation. Unlike Dabigatran, these can be crushed. With Rivaroxaban, you do need to be cognizant of where the tube is, if a patient is getting it through a G-tube. If it's post-pyloric, that wouldn't be recommended. It actually needs to end in the stomach. The other two, it wasn't found to be significant, but these medications can be crushed. And again, they do come with a pretty hefty price tag at greater than $400 a month for our patients without insurance. Note that as we're talking about these DOACs, they are expensive, but we do have patient assistance programs available for patients who do not have insurance, but some insurances won't pay for these medications and your patient is left with this price tag. So just keep that in mind. Ultimately, the benefits of our factor Xa inhibitors is that there's no laboratory monitoring or no routine monitoring, minimal drug interactions, significant ischemic stroke reductions in some, there was reduction in all-cause mortality in some, and there was decreased bleeding, GI bleeding, especially in Apixaban, or it was found to be not significant compared to warfarin. These can be expensive. There is limited monitoring and controversy in non-compliant patients. As we sum up the DOACs, remember that there is no direct DOAC head-to-head trial, and therefore we don't have significant evidence to prefer one over the other. We have to take a look at the differences in the study population and think about our patient-specific factors. Special populations should be given extra consideration when selecting an oral anticoagulant. While warfarin is the drug of choice in severe renal impairment, patients with renal disease were seen in sub-studies of the 5 large DOAC trials, and they were found to have an increased risk of ischemic events, bleeding, and all-cause mortality. But when the DOACs were teased out and evaluated in these patients, they were consistently similar to or better than warfarin in the prevention of stroke and systemic embolism and bleeding events. However, additional larger studies are needed. I know that since these patients weren't included in the big landmark studies, you can find smaller studies, small meta-analysis that evaluate these, but the evidence still isn't as great. So when you have a patient with severe renal impairment, warfarin is still considered the drug of choice. But DOACs can be considered in patients who are not tolerant to or cannot be on warfarin therapy. Again, with elderly patients, we do have the higher incidence of atrial fibrillation, but in these patients, we also have the higher incidence of bleeding. There were 14 studies that included observational, randomized controlled trials, and the sub-studies of our larger studies that showed that there are similar or decreased risk of stroke, systemic embolism, and bleeding compared to warfarin, but only Apixaban was noted to have lower rates of bleeding compared to warfarin. So Apixaban may be considered a drug of choice in some of our elderly patients. However, you have to consider all the other factors about your patient, the renal function, compliance, the ability to afford when considering that your drug of choice. Additionally, with elderly patients and aging comes the increased risk of falling. This is a significant source of morbidity, disability, and decreased activity. However, it's estimated that a patient would have to fall 295 times a year for the risks of anticoagulation to outweigh the benefits in AFib-related stroke prevention. This only evaluated warfarin, and there was only one single sub-study of ARISTOTLE that suggests there was no difference in treatment outcomes with Apixaban compared to warfarin in patients who were deemed high risk or had many falls a year. Additional considerations, or this is what I call more practical considerations, can be summed up on this slide. So patients who are at high risk of GI bleeding, you want the agent that has the lowest incidence, and that's going to be Apixaban. Patients who have high overall bleeding risk, you're going to want to consider the agents with lowest overall bleeding, and that could be Apixaban or Edoxaban. However, please note that the Edoxaban 30 milligrams is usually where a lot of evidence would say it has similar bleeding rates to Warfarin, but there is more data coming out with the Edoxaban 60 milligrams that may suggest it has lower rates of bleeding as well. In patients with active dyspepsia, avoid Dabigatran-related dyspepsia and use our factor Xa inhibitors. Patients who are unable to swallow or have to use intraoral feeding tubes or PEG tubes, choose an agent that has the ability to be crushed, and that's going to be our factor Xa inhibitors, and not to use Dabigatran. Inconsistent food intake, choose agents that do not require food for absorption. That's going to be Apixaban, Edoxaban, or Dabigatran. Avoid Rivaroxaban in these patients. In patients with good renal function, you want to avoid Edoxaban with a clearance in patients with a clearance greater than 95 mL per minute, and choose Rivaroxaban, Apixaban, or Dabigatran. Like special populations, special circumstances should be evaluated when selecting an oral anticoagulant. Oral anticoagulation initiation and selection after an acute ischemic stroke should be done cautiously. This is often based off provider clinical judgment, as there is a lack of consensus as to when this should be started in patients. This is usually based off of patient stroke size and severity, hemorrhagic transformation, and overall patient bleeding risk, and the acuity of anticoagulation. If a patient has an active thrombus, that might necessitate earlier anticoagulation than originally intended. There is the Heimbuchel's rule of 1, 3, 6, 12 days, to which you can utilize as a skeleton for when to consider starting anticoagulation. However, overall, look at your patient. But this says that in patients who are stable with atrial fibrillation needing anticoagulation after a TIA, that this could be started within 1 day. Small, non-disabling strokes, consider starting in 3 days. Moderate strokes in 6 days, and larger territory strokes. Instead of 12 days, it's really 2 to 3 weeks, but just consider a longer duration to allow healing to occur in these large territory strokes, and therefore decreasing patients' risk of bleeding. Similarly, there is limited evidence as to which oral anticoagulant and when to start after an intracranial hemorrhage. Overall, this is considered an off-label indication, as most of these patients were excluded from the major studies. But recent data shows improved outcomes with reinitiation after intracranial hemorrhage in select patients. This is more going to be a risk versus benefit analysis. The timing is everything, and there is differing opinions, and there's no consistency. So the American Heart Association, American Stroke Association says you probably could do it within 7 to 10 days. European Stroke Initiative says within 10 to 14 days, but then their opinions go all the way out to 30 weeks. So it is variable. It really just depends on your patient. A lot of this was studied with Warfarin, these timing dates, and the DOACs are still being evaluated. You can see some smaller meta-analyses from different hospitals, even one coming out from Grady, that looks at what we're doing with these patients and when we're starting and what are the risks. Ultimately, many patients who are on oral anticoagulation will need interruption in their therapy due to procedures. For Warfarin, it should be held 5 days prior to a procedure and then resume within 24 hours. You will have to ask yourself, does your patient need a bridging agent at this point? Patients with active clot or high risk of clotting may need a parenteral bridging agent with low molecular weight heparin or unfractionated heparin. For our direct oral anticoagulants, this should usually be held 24 to 48 hours prior to a procedure, usually no more, and they don't require bridging and can resume within 24 to 72 hours, depending on the procedure and the patient's bleeding or bleeding risk after the procedure. In patients who are bridged with warfarin therapy, low molecular weight heparin can be held anywhere from 12 to 24 hours prior to a procedure, and again, resume within 24 to 72 hours. The quickest of the agents would be our unfractionated heparin infusion, which can be held 4 to 6 hours prior to the infusion and resume within 12 to 24 hours. For patients who we're most worried about or highest risk of bleeding, you could consider unfractionated heparin infusion in these patients. So what happens when our drugs work too well or we overshoot our goal and a patient is bleeding on an oral anticoagulant? It's good to know that anticoagulation therapy in its nature exposes the patient to a higher incidence of intracranial hemorrhage and extended hematoma expansion. But not all patients need to be reversed. We need to assess the urgent need of reversal, and this should be done in patients with life-threatening bleeding or urgent surgeries or procedures. Identify the half-life of the associated medication, as patients with renal impairment are likely to have extended exposure to the medication, or if the patient ingested more than the standard dose, they will have extended exposure to the medication. Consider whether expedited elimination is possible or feasible in your patient. This can include activated charcoal in patients with an ingestion less than an hour from presentation, or hemodialysis for Dabigatran only. And then you should assess whether your hospital has access to any of the targeted reversal agents. Targeted reversal agents can include vitamin K, Prothrombin complex concentrate, Idarucizumab, and Andexanet Alfa. For warfarin, IV vitamin K can fully reverse anticoagulation. It's available IV or PO, and they have variable durations in patients. But the peak we are pretty confident in, and that's the IV peak in 12 to 24 hours, with the PO therapy peaking in 24 to 48 hours. So if you have a patient with an urgent bleed, we're going to recommend IV therapy. This is usually 5 to 10 milligrams, with our more significant life-threatening or intracranial hemorrhages being the 10 milligrams IV. But this does come with the risk of anaphylaxis with IV therapy, so we don't use this openly. We're very judicious about our IV therapy just because we want to reserve it for the patients who truly need it. In addition to vitamin K for warfarin-related bleeding, Prothrombin complex concentrate, this comes as a 3-factor or 4-factor, so you'll want to see what your institution has, but most commonly now we're seeing more 4-factor PCC products, and that's going to be Kcentra. It's a combination of the factors that warfarin inhibits, 2, 7, 9, and 10. And in combination with vitamin K, it can fully reverse warfarin-related bleeding with an INR reduction seen within 10 minutes. However, even though it's formulated for warfarin-related bleeding, it may help in DOAC-related bleeding. The dose is going to be weight-based with a maximum dose of 5,000 units, and it is contraindicated in patients with disseminated intravascular coagulation, or DIC, or patients with heparin-induced thrombocytopenia, or HIT. This is because this product is co-formulated with a little bit of heparin, and it can complicate therapy in these patients. We will monitor for hypotension, tachycardia, thrombosis, and anaphylaxis when administering this medication. And the costs are variable given that it's a weight-based medication, but you can expect up to approximately $10,000 per dose if you're utilizing the maximum dose of 5,000 units. In the past few years, we've begun to get more targeted reversal agents, beginning with Idarucizumab or Praxbind. This is a humanized monoclonal antibody used to the reversal of Dabigatran only. Unlike Kcentra, this is a fixed dose. It's a 5-gram IV bolus given to every patient. But unfortunately, the manufacturer formulated it as 2-gram vials. So then we have to do 2-gram subsequent vials. So if a patient is getting Idarucizumab, make sure they get the second vial. Some people do forget that and the patient's not getting the full dose. Additional doses may be required in the setting of excessive Dabigatran concentrations. You could see the need for hemodialysis in these patients as well. And then it does not independently cause hemostasis. It does have low rates of hypersensitivity, given that there's approximately 350 times greater affinity for Dabigatran than for thrombin. It kind of runs an interception for Dabigatran, and it is less costly per dose. It's approximately $3,500 per dose. In just this year, there has been the approval of Andexanet Alfa or Andexxa. This is a factor Xa inhibitor decoy molecule developed for the targeted reversal of Apixaban or Rivaroxaban. However, it's theorized that it could also reverse Idarucizumab and enoxaparin. However, it only is approved for Apixaban or Rivaroxaban. Unlike our other agents, this is an IV bolus followed by a 2-hour infusion due to its short half-life. And some patients who may have surgical bleeding as well may require a prolonged infusion. And the dose and duration of the infusion is going to depend on the 10A inhibitor that was ingested and the time of the last dose. Unlike all of our other agents, this does come at a hefty price tag of approximately $26,000 to almost $60,000 per dose. So, given the parameters for each of the reversal agents and patient-specific factors, how can we effectively use these costly agents? So, by using the degree of urgency and severity of bleeding, if a patient has minor bleeding or there's no rush to reversal, you can withhold the drug, monitor clinical status, and check laboratory tests. Just remember for calibrated tests, and a lot of these patients are eccrine clotting time and Dabigatran. For expedited reversal or patients with major bleeding, withhold the drug. In Dabigatran, consider Idarucizumab or 4-factor PCC at 25 units per kilo if it's not available, or hemodialysis. You can consider that activated charcoal if a patient has ingested in less than an hour. For factor 10A inhibitors, you can do the same Andexanet Alfa, although that does have limited availability. But you can use Kcentra or a 4-factor PCC product at 25 units per kilo. For emergent reversal or major bleeding, you'll want to still consider the same properties. However, in Dabigatran, don't forget about your hemodialysis again, and you'll want to up the dose of your 4-factor PCC to 50 units per kilo. And your factor 10A inhibitors, you'll want to do the same. You'll probably want to do that edge of 50 units per kilo, or if you do have Andexanet Alfa, you can consider that. Again, this is for our DOACs. Don't forget for Warfarin, IV vitamin K, 10 milligrams, and as well as the weight-based dosing and based off of INR on your Kcentra. As we near the end of the presentation, I want to conclude with some takeaway points. So DOACs do have proven efficacy in stroke prevention in patients with atrial fibrillation. However, despite their wide acceptance, selection should be based off of patient-specific criteria. Don't forget that warfarin remains the drug of choice for patients with valvular atrial fibrillation and severe renal impairment. And reversal of these agents should be done cautiously based on the medication and patient-specific factors. Future research in this area should focus on expanding the DOAC indications and the population of patients to receive these medications through randomized controlled trials in specific special patient populations such as cancer, HIT, and atrial thrombus. The utility of DOAC-specific laboratory values, although many hospitals are adapting these calibrated values, we need to know how and when to use them, as well as look forward to some head-to-head studies between these agents and the development of the universal reversal agents, the Parentag, and its role in anticoagulation reversal. And with that, I'll be happy to take any questions.
If you have any questions, thank you so much, Libby, for that awesome presentation. If you have any questions, please feel free to unmute yourself and ask your question, or you can type it in the chat box and I can read the question. We have about 10 minutes, about 12 minutes for questions.
Hi, Libby. Can you hear me?
I can.
Hi. That was really terrific. This is Mike Frankel again. It's a very, very complex decision tree, getting more complex. the medications, the issues that you outlined in terms of considerations. The drug, this universal drug that you mentioned, what is the, maybe you mentioned it at the end, but what do they, how is that going to, what's its mechanism of action?
Right, so its mechanism of action is designed almost how warfarin inhibits a lot of different factors. It's going to be almost like a universal blocker per se to help reverse a lot of, like almost all of our anticoagulants and run interference on them. It's still in the pipeline, so I think it's still being fully developed and its mechanism is still being fully elucidated. I don't expect that it would come to market anytime soon, but it is something that we should be looking forward to.
Thank you. I'm sure it will be very expensive knowing how this stuff rolls out, but hopefully not. What comments can you have about the availability? Most places aren't doing the Eckerin clotting time, and if they are doing it, it doesn't come back quickly enough. We have the considerations of, which you didn't touch on, in terms of TPA and decisions about giving TPA. What can you comment about in terms of decisions about giving TPA with these drugs?
That's a great question, just because as you read the acute stroke guidelines, there is the section that says if your patient has not had a dose within 48 hours, and I think there's some misinterpretation of that section because a lot of people will say if they've had a dose in 48 hours, we can't do it. But they say if we had a dose in 48 hours, but their labs are normal, then you could consider it. I think there was, like over a year ago, there was probably even more limited evidence, but as you look with Dabigatran, there are some people who are looking at these Eckerin clotting times and saying, well, my patient did have a dose this morning, but their Eckerin clotting time is normal, and they have evaluated with giving TPA or sometimes less frequently reversal with Idarucizumab and TPA. However, this is still, in my opinion, still a little bit risky to reverse and then give TPA. I wouldn't recommend that. However, I think if your institution could easily do an Eckerin clotting time, which tends to be the most sensitive for Dabigatran, and get that evidence back to help corroborate a story, then you could consider it for alteplase administration. However, like you said, this can be challenging with many institutions to get that information back in a timely manner. So it's always recommended to use clinical history as the biggest driver for alteplase administration. But I have a feeling in the future with more calibrated anti-factor Xa inhibitor labs, as well as quicker Eckerin clotting times, there's going to be more evidence to come out to say how we should be using these, what are the cutoff values, and when you could give alteplase in the setting of someone who is on these agents who have either normal or abnormal tests.
Thank you. Maybe other people have questions.
We do not have any questions in the chat box at this time, but if anyone has questions, any other questions for Libby, she will be glad to take them. We have a few more minutes.